So picture this. You are in the clinic.
Right.
You've mapped the patient's motor threshold, right?
Yeah.
You've positioned the coil.
Yep.
You know the exact angle, the exact intensity required to target the dorsolateral prefrontal cortex.
You've done it 1,000 times.
Exactly. I mean,
Yeah.
as a psychiatrist or a healthcare provider listening to this right now, someone who is already actively practicing transcranial magnetic stimulation, the mechanics of the device are just, second nature to you at this point.
Yeah. It's muscle memory.
Right. You know how to operate the machinery.
Yeah.
But the thing is, mastery of the physical device is really just the entry fee here.
Totally.
So today is not about the basics of how to run a coil. Today's about the horizon of the neuromodulation field. The shifting language we use to define our clinical value and really where your practice is actually headed next.
Exactly. Because, operating the technology efficiently is one thing, right?
Yeah.
But understanding exactly where that biological intervention fits into the rapidly evolving ecosystem of modern psychiatry.
Right, the bigger picture.
Yeah, that is where the real clinical value lies. Because we are moving far beyond just, applying a magnetic pulse and just sort of hoping for the best.
Oh, absolutely. But before we unpack the mechanisms of that shift, let's set the stage really quickly.
Okay.
This podcast is brought to you by the Blossom TMS team at Sabres Medical. This podcast is for psychiatrists and providers that are not new to TMS therapy, but want to stay updated on trends, value, and future of TMS.
Perfect.
And to do that, we're looking at this fascinating source text today, Integrated Care in the Era of Brain Stimulation.
Yeah, it's a great piece.
It really is. And our mission today is to explore how the language and the conceptual framework around TMS is just radically shifting. We're moving from isolated symptom-based treatments to this highly coordinated systems-oriented model.
And that shift is huge. The central shift we are seeing across the entire discipline right now is a fundamental move away from those isolated treatments.
Right.
Because for a very long time, psychiatry operated in incredibly rigid silos.
Oh, yeah. Like totally walled off from each other.
Exactly. You had your pharmacology and your medication management happening in one room.
Yep.
And then you had psychotherapy happening down the hall or, more likely in a completely different building.
Yeah, usually crosstown.
Right. Neurology was treated as its own distinct, purely physical island. And behavioral interventions, they were practically a separate discipline entirely.
It's wild to think about that old model now.
Yeah.
We treated the mind and the biological brain like they were in two entirely different ZIP codes.
That's exactly what it was.
To put it in perspective, it was like trying to fix a complex citywide traffic grid failure using just entirely disconnected strategy.
Yeah, I like that analogy.
Right, like pharmacology was basically sending out a blanket smog of chemicals to just slow down all the cars across the entire city.
Just slowing everything down everywhere.
Yeah. And psychotherapy, meanwhile, was standing on a single street corner trying to teach individual drivers to take better routes.
Wow.
But the crazy part is, nobody was actually looking at the highway infrastructure itself. Nobody was redesigning the roads.
And that is precisely the limitation of the siloed era. But, that separation wasn't necessarily malicious or intentionally ignorant.
Right, it's just what we had.
Exactly. It was just a reflection of the tools available at the time. You treated the presumed chemical imbalance with an SSRI.
Yep.
And you treated the cognitive distortions with talk therapy. But as our ability to look at the living brain evolved...
Oh, the imaging.
Right. Specifically, our understanding of resting state, functional connectivity, and large-scale brain networks. That compartmentalized approach was basically forced to collapse.
Because we aren't just talking about basic fMRI scans anymore, right? Like, as a provider listening to this, we aren't just marveling at the fact that the brain lights up when someone thinks about a sad memory.
No, we're way past that.
We started identifying the specific network failures that were actually driving these pathologies. We started looking at the default mode network and seeing the physical hyperconnected loops of rumination in a depressed patient.
Exactly, the actual physical loops.
Yeah, and we looked at the salience network, the executive control network.
Right.
And we realized that major depressive disorder or, severe anxiety, it isn't just a localized chemical hiccup in one synapse.
No, not at all.
It is a complex, overlapping network failure.
And because our understanding of the biological brain shifted from a chemical model to a network model, The way we structure our actual clinical clinics had to change to mirror that reality.
Right.
I mean, you cannot treat an interconnected neural network with a disconnected clinical team.
Oh, that's a great point.
Which brings us to the phrase that is suddenly ubiquitous in every piece of modern academic literature and at every clinical conference right now.
Let me guess. Integrated care.
Integrated care,
Yeah.
exactly.
Okay, and I have to pause here. I need to push back on that exact phrase on behalf of every provider listening right now.
Uh-oh. Okay, go for it.
Because honestly, whenever I hear the words integrated care or multidisciplinary pathway, my administrative alarm bells immediately start ringing.
Oh, I totally get that.
Right. In the real world, integrated care usually sounds like corporate homogenization.
Yeah, it sounds like more paperwork.
Exactly. It sounds like an administrative nightmare where every single clinic is forced to adopt the exact same unified, rigid workflow.
Just a total bottleneck.
Yeah. It sounds like endless bureaucratic integration where the therapist, the prescribing psychiatrist, and the TMS technician all have to fill out the exact same 40-page intake form before we can even touch a patient.
That is the natural and honestly completely justified fear. When healthcare providers hear integration, they instantly picture a bloated, top-down administrative mandate.
Right, because we've all been there.
We have. But here's the thing. True integration, in the context of neuromodulation, does not imply identical, rigid workflows across every single practice.
Okay.
The text makes this super clear. A boutique private practice is not going to have the same logistical workflow as a massive university hospital system.
Right, and they shouldn't.
Exactly, they shouldn't. The framework has to be highly flexible. It depends entirely on your specific specialties, your staffing models, and your patient demographics.
So it's not a one-size-fits-all thing.
Not at all. Integration is not about identical paperwork.
Okay, so if it's not about forcing everyone into the exact same operational mold and using the exact same charting software, what is the actual mechanism of integration? Like, how does it practically function on the clinic floor?
It functions through conceptual alignment and workflow synchronization.
Conceptual alignment.
Yeah, it is about ensuring there is a strategic continuity across the patient's experience. Let me give you a very practical example from the clinic. So, if a patient is receiving an intermittent theta burst protocol, you are actively inducing a localized window of intense neuroplasticity.
Right.
That brain is suddenly highly malleable.
Right, it's primed.
Exactly. So if that patient finishes their TMS session and immediately goes home to sit in a dark room and ruminate,
Oh, wow.
you have largely wasted that acute window of plasticity.
Oh, that makes perfect sense. So true integration really means scheduling.
Yes.
It means the prescribing psychiatrist understands the biological mechanism of the TMS and then works with the administrative coordinator.
Exactly.
So they schedule the patient's trauma-focused cognitive behavioral therapy for exactly 30 minutes after the magnetic coil comes off their head.
Precisely. That is integration. The therapist needs to understand how that specific cortical stimulation is impacting the patient's emotional availability and, their cognitive flexibility in real time.
That is so cool.
And the psychiatrist needs to know how the downstream effects of the neuromodulation interact with the patient's current pharmacological load.
Right, because things are changing chemically too.
Exactly. Perhaps the TMS is upregulating certain receptor sensitivities, which means the patient's SSRI dosage needs to be actively tapered to avoid overstimulation.
Wow.
It's all about a shared understanding of the patient's biological journey.
And achieving that shared understanding requires an entirely new lexicon, doesn't it?
It really does.
Because the old pharmacology exclusive language, talking strictly about serotonin or dopamine receptors, it's completely incomplete for what you are doing in a modern clinic.
Totally insufficient.
It's like trying to describe how the global internet works by only talking about the physical copper wiring.
Yeah.
You're missing the data routing, the servers, the actual network traffic.
It absolutely isn't complete, and that's why the standard terminology is shifting so rapidly right now.
Right.
As a provider, your charting, your peer-to-peer consults, and your patient education, they are now revolving around terms like brain circuitry, neural connectivity,
Functional networks.
functional networks, exactly, neuroplasticity, and multimodal care.
I want to focus on neuroplasticity for a second, actually, because this is where the how and the why of integrated care really crystallize for me.
Let's do it.
We throw that word around a lot, right?
Yeah.
But let's look at the actual mechanism of what happens in the clinic. When you deliver a sequence of magnetic pulses to the prefrontal cortex, you aren't just temporarily numbing a symptom.
No, not at all.
You are inducing an electrical current that causes underlying cortical neurons to fire synchronously.
Right.
And when you repeat that over a 36-session protocol, you are leveraging long-term potentiation and long-term depression. You are physically altering the synaptic strength.
You're thickening dendritic spines.
Exactly.
You are changing the physical architecture of the network. You are lowering the threshold required for those neurons to communicate.
To use another analogy here, and I think this really captures why integrated care is non-negotiable, TMS is essentially a snowplow.
Okay, a snowplow. Walk me through that.
Right. Imagine you have a patient with severe treatment-resistant depression. Their neural pathways, their ability to reframe negative thoughts, they are completely blocked off, frozen over. So psychotherapy is the delivery truck trying to bring vital supplies to the house.
Right. The new coping mechanisms, the cognitive reframing.
Exactly. The behavioral activation.
Yeah.
But if the road is buried under 6 feet of solid ice, it doesn't matter how good the delivery truck is.
No.
It is never getting to the destination.
That is a phenomenal way to visualize the mechanism.
Right. So the TMS coil is the snowplow. It forcefully clears the road. It forces the neuroplasticity to open the pathway.
Yes.
But, and here's the crucial integrated care piece, clearing the road doesn't automatically put the supplies in the house.
Oh, wow. Yeah.
You have to actually drive the therapy truck right through that cleared pathway while the road is still open.
Well, it's clear.
If you plow the road and don't send the truck, the snow just piles back up. The biological intervention primes the system, but the behavioral intervention rewires the system.
Which brings us to the reality that you cannot execute that kind of highly choreographed, multimodal treatment plan without a deeply synchronized human network on the clinic floor.
Exactly.
If you want the patient's neural networks to communicate effectively, your clinical team's communication network has to mirror it.
And that involves redefining the value of everyone in the room,
It really does.
particularly the people who are spending the most time with the patient.
Right.
Let's talk about the multidisciplinary human network required to pull this off, starting with the TMS technicians.
The technician is arguably one of the most underutilized clinical assets in a traditional siloed model.
Totally.
But in an integrated model, they are the longitudinal observation wing of your clinic.
Yeah.
I mean, think about it. The prescribing psychiatrist might see the patient once every 2 weeks for a brief med check.
Right, if that.
And the therapist sees them for 45 minutes a week. But the TMS technician, they are sitting with that patient for a treatment session 5 days a week for 6 straight weeks.
The sheer volume of observational data the tech gathers is just immense.
Oh, yeah.
They aren't just button pushers, they are data collectors. They see the exact moment the patient's personal hygiene starts to improve.
Yes.
They measure the patient's speech latency every single morning. They notice the micro expressions.
Right.
They see that, on day 14, the patient actually makes sustained eye contact when they walk into the room, whereas 2 weeks ago, they just stared at the floor.
And in a poorly integrated clinic, that vital behavioral and emotional data, it just stays locked inside the TMS treatment room.
Which is such a waste.
It is. The tech notes it, maybe writes it in a siloed chart somewhere, and no one else acts on it.
Right.
But in a truly integrated, systems-oriented model, there is a deliberate feedback loop. That data flows immediately to the care coordinator, who flags the therapist to, say, lean into a specific trauma protocol because the patient's effect is currently elevated.
Wow.
And it flows to the psychiatrist, providing the empirical justification needed to begin safely tapering a complex pharmacological cocktail.
It's treating the patient as a continuous dynamic biological system rather than just a static snapshot.
Exactly.
You are adjusting the care in real time based on high-frequency clinical observation.
And if we take that concept of high-frequency observation and real-time adjustment to its logical conclusion,
Oh, here we go.
we arrive at the true horizon of the field. This is where integrated care is inevitably heading next.
Okay, tell me.
It's the intersection of neuromodulation, digital psychiatry, and longitudinal biomarker tracking.
Man, this is the stuff that sounds like science fiction. But as a provider listening, you know the underlying technology is already sitting in your patient's pockets.
Oh, 100%.
We are talking about moving beyond subjective patient reporting, waiting for the patient to come in and just say, I feel sad today.
Right.
And moving toward a highly objective data ecosystem.
Exactly. Let's walk through a concrete example of what this looks like for the clinician of the very near future. Let's look at a hypothetical patient named Sarah.
Okay, Sarah.
Sarah has a history of severe depressive relapses, and she has successfully completed an initial TMS protocol. Under an integrated, data-informed care model, Sarah's treatment doesn't just end with a handshake and a "see you next year."
Right. Because Sarah's wearing a standard consumer smartwatch that tracks her autonomic nervous system function.
Yeah.
And she probably has an app on her phone that utilizes ecological momentary assessment and acoustic voice analysis during her daily phone calls.
Precisely. It's constantly running in the background. And one Tuesday, the system flags a subtle but sustained drop in her heart rate variability.
Uh-oh.
Simultaneously, the acoustic analysis detects a flattening of her vocal effect, and her actigraphy data shows she hasn't left her apartment in 48 hours.
Wow. And Sarah herself hasn't subjectively realized she's entering a depressive plunge yet.
Exactly.
She hasn't called the clinic.
But the clinical dashboard flags it. The integrated system sees the network failure beginning before the clinical relapse fully manifests.
That is incredible.
Yes. So the system alerts your clinic's care coordinator. The coordinator proactively reaches out to Sarah and brings her in. Not for a full 36-session overhaul.
Right, because it's early.
Exactly. Just for a targeted 3-day theta burst booster protocol to restabilize the network.
Okay.
And simultaneously, her therapist receives the alert and adjusts her behavioral homework for the week to focus heavily on behavioral activation.
That completely flips the paradigm of psychiatric care.
It really does.
You are intercepting the pathology. You are dynamically adjusting the neuromodulation protocol based on continuous digital biomarkers.
You're getting ahead of it.
It makes the treatment a living, breathing ecosystem around the patient rather than a static event that only happens when the patient hits rock bottom.
That is the ultimate promise of integrated care in the era of brain stimulation. It ensures treatments are highly personalized, highly proactive, and constantly adjusting over time based on objective biological data.
So as a provider listening to this, the core takeaway is a profound shift in how you should view your own practice and your own professional value.
Yep.
Your value isn't just in knowing where to place the magnetic coil. It's in how effectively you orchestrate that technology within the broader biological, behavioral, and digital ecosystem of your patient's life.
Exactly.
It's about how you connect the dots between the plowing of the neural road and the delivery of the therapeutic supplies.
It is the fundamental difference between simply executing a localized medical procedure and actively practicing systems-level integrated medicine.
Amazing. Well, before we wrap up this analysis, a quick reminder to our listeners. For more information about brain stimulation technologies and clinical solutions, visit Blossom TMS Therapy System. Let's connect at +1.833.328.9867.
And as you think about how to apply these integrated frameworks to your own clinical practice, I want to leave you with one final concept to mull over.
Okay.
Something that builds on this intersection of digital biomarkers and continuous neuroplasticity.
Just hear it.
If true integrated care means we are eventually going to be tracking digital biomarkers and mapping neural connectivity in near real time, it raises a fascinating question about the evolution of your specific role.
Right.
Will the neuromodulation provider of the future be less of a traditional diagnostician waiting for a patient to report symptoms and more of a network conductor, literally syncing a patient's daily real-world behavioral therapy with their real-time brain plasticity?